Stroke is an umbrella term that means loss of neural tissue. It's not very helpful because it doesn't tell you anything about the etiology or the management. So I'm going to start off by talking about the different types of strokes because it's obligatory, and then focus this lesson on what I call obstruction strokes, those that are amenable to IV TPA, alteplase, and treatable with endovascular thrombectomy. And you're going to see that it goes from high yield to low yield, left to right, and it goes from high level to more detail, left to right. So let's start off with the different types of strokes, illustrating why stroke as a term is unhelpful. The usual distinction is that between hemorrhagic and ischemic. And a hemorrhagic stroke is a brain bleed. That is going to be managed by neurosurgery and see subspecialty surgery for more details. You're certainly not going to treat a hemorrhagic stroke with TPA or thrombectomy. In fact, that is the risk of giving or using those therapies. So above this line is hemorrhagic, and below this line is ischemic. The first of the ischemic strokes is global hypoperfusion, as occurs from hypotension, shock, cardiac arrest. Also not treated with IV TPA or thrombectomy. This is going to affect the watershed areas, territories between vascular territories. The third and fourth are the ones that matter for this lesson. Rupture and thrombosis, that is atherosclerosis, rupture of an atherosclerotic plaque, thrombosis of the vessel, and an embolism. Specifically, an embolism of a thrombus. Because there are other emboli, like septic embolism, also not treated with IV TPA or thrombectomy. So I chose to use a term, it sounds funny, but one that was not taken by words that sound like it. Obstruction strokes. Obstruction strokes are defined by the ability to treat with IV TPA and mechanical thrombectomy, and that's what we're going to talk about in this lesson. Much like a heart attack, an obstruction stroke is an acute change, and it becomes a supply ischemia issue. But because technically, a hypoperfusion is a supply ischemia issue as well, an obstruction stroke is specifically supply ischemia caused by a focal blockage. And most of the time, the patients who get obstruction strokes are those who have cerebrovascular disease or disease of vessels leading to the brain. And so atherosclerosis is the predominating feature. There are non-modifiable and modifiable risk factors for atherosclerosis. The non-modifiable are going to be age and sex, 45 for males, 55 females, and a family history. The modifiable risk factors are going to be diabetes, chronic kidney disease, and atherosclerosis somewhere else, which is why if you have atherosclerosis somewhere else, you get heart and brain prophylaxis. These three are coronary artery disease equivalents. Other ones are hypertension, dyslipidemia, obesity, and smoking tobacco. Now, in addition, because there's more than just rupture and thrombosis, you might have not this substrate, but have something that puts them at risk for a thrombus, which is AFib. The brain, cerebellum, brainstem. When there is an infarction, a stroke, there's going to be the tissue that's lost. That's the core. In addition, there's going to be a territory around it that if you don't do anything, it will die. But that's tissue that can be saved. That's the penumbra. And when we intervene, what we're trying to do is save the penumbra. The core is the risk by reperfusing or giving a clot buster that you can turn that infarcted area into a hemorrhagic stroke. A patient with a stroke can present with any focal neurologic deficit. Because an infarction can occur anywhere that there's neural tissue. I want you, though, to start thinking about only the cerebral vasculature. And what that does is gives us several vascular territories. The first distinction is anterior versus posterior. We're looking at the circle of Willis. The posterior circulation comes from the basilar artery, which comes up to the circle of Willis and then bifurcates to form the two posterior cerebral arteries, the left and right. Then the anterior circulation is going to be two vessels. The first is going to be the left internal carotid artery as it gives off the branch, the left anterior cerebral artery. The left internal carotid artery becomes and continues as the left middle cerebral artery. And on the other side, there is the right internal carotid. It branches the right anterior cerebral artery, and the right internal carotid continues as right middle cerebral artery. Now, of course, there are communicating arteries between them, between the anterior cerebral arteries and between the middle and posterior cerebral arteries, but because they're connecting branches, they're tiny slivers, and strokes occur distal to the blockage, I want you to start thinking about three territories: ACA, MCA, and PCA, and then left versus right. Right-sided stroke, left-sided symptoms. So while any focal neurologic deficit can be indicative of a stroke, you should identify three syndromes: an ACA stroke, which is going to have sensory and motor deficits of the feet and legs; the middle cerebral artery stroke, which is going to have sensory and motor deficits of the face, hands, and tongue, which means issues with swallowing, and if it is in the dominant hemisphere, issues with speech, both formation and interpretation. And lastly, the posterior cerebral artery stroke syndrome is going to be mainly vision changes and sometimes syncope. But any focal neurologic deficit can trigger a stroke workup. And if the focal neurologic deficit is determined to be a stroke and the stroke button is pushed, the workup includes the following. The first thing you're going to do is a non-contrasted CT of the head. You're going to rule out a brain bleed, because if it's brain bleed, you don't follow anything else. That's not going to come on this board. Then you're going to get a CT angiogram, and I want you to see this together with the perfusion study, usually CT. These are going to be used in the workflow to determine thrombectomy. The non-con CT head rules out bleed, thus opening the door for TPA. And then ultimately, usually not involved in the first day, the best radiographic test is an MRI, specifically the diffusion-weighted images. And as we go through the board, I'll go into more details, but the treatment for a stroke begins with, can you give TPA? That is intravenous alteplase, the clot buster. Separately, independently, but also considered at the same time, do you perform an endovascular thrombectomy? There's going to be some consideration for blood pressure. If you do not intervene, there's going to be permissive hypertension, 220/120 for the first 24 hours, versus controlling the blood pressure in order to give intervention, such as alteplase. To start, you need to get it to 185 over 110, and then to continue it, it's 180 over 105. And also the antiplatelet. It's going to be aspirin 325, then 81. When you give it is going to be dependent on whether or not they're getting alteplase, because it increases the risk of bleeding, but get the aspirin 325 on as soon as you possibly can. This is sort of the acute management. There's other things that matter though, but I'm going to put them in the follow-up category. You're going to work on these things even as you're considering the TPA and the endovascular thrombectomy, etc. But these are things that are essentially cooking in the background. You want to consider etiology, things like AFib, getting telemetry, a mural thrombus, getting an echo, and working up carotid artery stenosis, which can be achieved with the CTA or a duplex ultrasound. Functional status is very important, and you're going to achieve understanding of their functional status by consulting the specialists. Physical therapy, occupational therapy, and speech therapy. They'll help determine functional loss and disposition for rehab. And if it is a stroke, you want to do secondary prevention. And since most strokes are cerebral vascular disease or atherosclerosis, you're going to do atherosclerotic treatment in any other artery, which is platelet monotherapy, either aspirin 81 or clopidogrel 75, a high-potency statin, atorvastatin, rosuvastatin, and risk factor control. Get control of the blood pressure, the blood glucose, prevent progression of CKD, and smoking cessation. And the main risk of treatment is hemorrhagic conversion. If you don't treat, you condemn them to permanent neurologic disability. If you do treat, there's a hope of recovering all of that deficit. But at the same time, there's also a risk of causing a brain bleed, which is generally worse than the initial stroke. And so the last thing before we get into the details is grading a stroke on the NIH stroke scale. This is a score of 0 to 32, with 32 being worse, 0 being no deficit. The cutoff is 5. The closer to 32 you get, the worse you are, the more likely you are to have permanent deficit and the more likely for hemorrhagic conversion. But 5 is a cutoff for consideration. Below 5 is considered a non-disabling stroke. And 5 or more, disabling. And being disabling means it is a candidate for TPA and thrombectomy. Now, you may only have a sliver of a defect, but if a singer has lost their voice, that might be worth the risk. The details we're going to get into, and you're going to see it's very individualized per patient. At your level of training, crosses 5 is disabling, is a candidate. Okay, so getting to the details, the first question is it a bleed? Because if it is, none of the things we're going to talk about matter. The only tests you need to give IV TPA is a non-con CT of the head and a blood glucose. In reality, person presses the stroke button, they get wheeled into the ER, 37 people are doing things, telemetry wires, IVs started, saline running, moving to the scanner. So the labs are going to come back by the time they're back from the scanner. But technically, all you need are these two things. Not hypoglycemia, not a bleed, can give TPA. The non-con CT shows you two things. Blood and bone are bright white. And the brain parenchyma is gray. Lighter gray than the dark gray of the ventricles, but certainly darker gray than bright white. See bright white where there's supposed to be brain parenchyma, that's the brain bleed. And this next piece sometimes screws up new learners. A hemorrhagic stroke is bright white on non-con CT. When there is ischemia that is not yet infarction, the CT is going to be normal. If you do nothing, you don't intervene, and it turns into an infarction, there is a stereotyped behavior on the CT. The first thing you're going to see is blurring of the gray-white junction. Then, as cells die, infarction, you're going to see evidence of cytotoxic edema. Edema is fluid, and fluid is dark gray. By the time you see obvious evidence of infarction, it is way too late. This is an old infarct and one that has an increased risk of hemorrhagic conversion. The ischemic stroke you want to intervene on is either going to be stone cold normal or only beginning the signs of infarction. So it's not that hemorrhagic strokes are bright white and ischemic strokes are dark gray. It's blood is white, old infarct is dark gray. If you decided it's not a bleed, the second thing you want to ask is, can we give IV TPA? And the TPA that's available now is Alteplase. If yes, Alteplase is given as an infusion, and that's in the ICU. You're going to have very close monitoring, both of the neurologic status and of the blood pressure. In order to start Alteplase, in order to reduce the risk of hemorrhagic conversion, you got to get the blood pressure below 185 over 110, and then to continue it below 180 over 105. And what agent you use doesn't matter. All the usual antihypertensive infusions can be chosen. And you choose to give it based on the last known normal. That is, when was the last time they were known to have no neurologic dysfunction? There's going to be talk about 4.5 hours versus 3 hours. 4.5 is what most centers go on. There's a lot of evidence of safety at 3, but 4.5. And for a licensing exam, a test question, if they want you to give TPA, it's going to be below 3 hours so that there's no question it's the right thing to do. However, modern practice involves not only time, but also imaging. Whether it's the CT non-con or perfusion study, it's getting more sophisticated. It used to be hard cutoff. If you went to sleep and your last known normal was 8 hours ago, you were excluded from TPA. Now, as we'll talk about at the end with wake-up strokes, is more of a combination of everything and how disabling and what's the risk. It's not a hard cutoff, but for your licensing exam, it will be. And so you don't give it to a TIA, that is, the symptoms that are getting better on their own. And because of the risk of hemorrhagic conversion, you don't give it to non-disabling strokes. And most importantly, you don't give it to anyone who has an exclusion criteria. And when you do this for real, there's going to be a literal checklist. So committing to memory all the reasons not to give it and their time relative to the stroke, not worth the squeeze. If a licensing exam wants you to exclude the patient from getting TPA, whatever the contraindication is going to be obvious and recent. But you should know some of them to have a sense for what they are. That is time, the presence of anticoagulation, and a reason to have a clot that will cause them to bleed out. We just talked about the 4.5 versus 3 hours, or evidence on imaging. If it's dark gray, chances are it's going to bleed. Coags, if the patient's on warfarin and the INR is over 1.7, if they're on a NOAC, 10A inhibitor or thrombin inhibitor, and they've taken it within 48 hours, or if they've received therapeutic heparin. DVT prophylaxis doesn't count. If they've ever had a brain bleed, don't give it. And then recent trauma, a recent surgery, or GI bleed, you don't want to give the TPA because all of the clots that are associated with that will open up and the patient will bleed out. So give it if there's going to be recovery, it's a disabling stroke, and the risk of hemorrhagic conversion is low. Alteplase is really good at getting the small and distal clots, those that are hard to reach with thrombectomy, which is good because the next consideration, endovascular thrombectomy, is really good at getting proximal and large. Because it involves getting the thrombectomy device into a blood vessel in the skull. It can be used only on large vessel occlusions and only in the anterior circulation. This is where we have good safety data. That means distal internal carotids, proximal MCA, ACA. The decision to do thrombectomy is completely independent of TPA. They can be used together or one, not the other. So much to say that if a patient's at a critical access hospital without opportunity for endovascular thrombectomy, TPA can be started there, patient put in an ambulance and sent to a tertiary center to be evaluated for thrombectomy. You can do both. The CT angiogram is practically achieved the same time as the non-con CT. They're in the scanner, push the contrast, scan them again. So practically speaking, non-con CT and CTA get done at the same time. But in terms of the workup, the reason you do the CT angiogram, and you do it of the head, neck, and top of the chest, is to determine access. Can an interventionalist get from the aorta to the occlusion? Is it practical? And the perfusion study is done to answer, is it worth it to try? Last known normal, 6 hours is the cutoff, and you can use thrombectomy up to 24 hours. You're always going to use the CT angiogram to determine if there's the ability to get to the clot. Within this first 6 hours, you don't need the perfusion study. It is safe and worth it. Between 6 and 24 is how you help answer what is the risk of conversion and how much penumbra is left to save. You won't have to interpret this. Just know that you do need it between 6 and 24 hours. It's very complicated. Patients take different paths, and with a number of imaging modalities, you're able to see how much brain has died, how much is left to save, and is it worth it to do the thrombectomy? These things are the hyperacute decisions you're going to make. The fourth thing will be worked up in tandem. That is the etiology. What caused the stroke? And the advanced organizer I use is a question mark with the dot being the heart. Heart, neck, head. Is it cerebrovascular disease? This can be answered with the CT angiogram or the MR angiogram. Is it carotid artery stenosis? We're going to talk about carotid artery stenosis in detail in the subspecialty surgery course. You work up carotid artery stenosis with the CT angiogram, or if you didn't get it, duplex ultrasound. And it is known in treating carotid artery stenosis for stroke, a carotid endarterectomy is very much preferred over carotid artery stenting. Because there was a stroke, symptomatic enough to intervene on it. And the timing is also important. Stroke happened and they've stabilized. Surgery should be done between 2 days, 48 hours after stabilization, but before the end of 2 weeks. It used to be wait at least 2 weeks. Now it's known that if there's a TIA or a stroke and there's 50% more stenosis, you should intervene early, but not during the evolution of the stroke. Increased risk of hemorrhagic conversion. And the heart is there to remind us of a couple of things. AFib, you're going to work that up with a 24-hour telemetry. That's going to start as soon as they walk in the door. And then you're looking for thrombus, whether it's mural thrombus, whether it's atrial appendage, vegetation, whatever. You look for that thrombus with an echocardiogram. And then almost never do you consider a patent foramen ovale. Patent foramen ovale found in lots of echoes. It's usually not a paradoxical stroke. However, in very specific patients, that is those who are young and who don't have any of this, right? There's no reason for them to have a stroke, no hypercoagulable disorder. It's called cryptogenic. It might be worth it in this specific patient population, because they have so long to live, to do a bubble study. That is an echocardiogram where you take some saline, agitate it, inject it. You see the bubbles go from the right atrium to the left atrium almost instantly. In patients who are young with cryptogenic stroke and a patent foramen ovale on a bubble study, consider closure. But in general, don't go after PFOs, don't do closure, but there's maybe a subset of patients where it's beneficial. All right, even deeper, things of lower yield, but still important. You might get to the point where you ask, well, is it even a stroke? Either the patient got better or you didn't intervene. The best test to tell if it's a stroke or not is an MRI. And again, diffusion weighted imaging. It takes a while to do the MRI, so generally it's the CT scans that are used for the hyperacute management. If you've had a resolution of symptoms and the MRI is negative, then you've had a transient ischemic attack. You have to have both resolution of the symptoms and no evidence of infarct on the MRI. With a diagnosis of TIA is the only time you're going to see DAPT near stroke. Dual antiplatelet therapy is given for 21 days to reduce the chance of this TIA becoming a full-blown stroke while you work it up, find out what the cause is, and fix it. If the MRI is positive, and you've had a cerebrovascular accident. And what you do about the cerebrovascular accident is dependent on whether or not you did an intervention. If there's not going to be an intervention, the patient gets aspirin 325 the first day. Rectally, orally, however it's going in, get the aspirin on board. And you do permissive hypertension. 220, 120. You're still going to do neurochecks. You're still going to likely put them in the ICU because you don't want the blood pressure to go up, and the stroke is evolution. A stroke that's done, it's over and already stabilized, that's different. If there is intervention, generally in the way of TPA, you're still going to do aspirin 325. It's a core measure. But you're going to do it only after 24 hours and a repeat CT of the head. If you get TPA, you get a non-con CT to make sure there's no evidence of bleed. And the blood pressure is kept 180, 110. even after the alteplase has stopped. Now you evaluate the patient for the risk of bleeding, but if they do bleed, you have to know what to do. The good news is, not hard to spot. The patient's going to have any focal neurologic deficit, get TPA, have resolution of their symptoms. And because you're doing Q1-hour neurochecks in the ICU, there's going to be any. It can be new, it can be the same one, it can be something different, any focal neurologic deficit or headache. It is unlikely that they're going to rethrombose in the exact same spot. The bleed can happen anywhere, generally in the spot that had infarcted, but it can happen anywhere, and it's going to cause compressive symptoms. So any new deficit, a headache or herniation syndrome, initiates diagnostic CT, non-con CT, to find evidence of the bleed. And before they're headed to the scanner, if it's running, you stop the alteplase. And when you diagnose the brain bleed, you call neurosurgery, see subspecialty surgery. And lastly, things that matter but don't warrant deep discussion. Other stuff. There was once consideration for seizure prophylaxis, especially in bleeds. Do treat seizures, do not prophylax them. The patients at biggest risk for hemorrhagic conversion are also at biggest risk for deep vein thrombosis. That is, the worse the stroke, the more disabling, the more bedbound they become, and the more at risk for a DVT they become. And people are worried about hemorrhagic conversion in the heparin. Well, definitely do SCDs and get them on low molecular weight heparin as soon as possible. Of course, if they didn't have a disabling stroke or they got better, ambulation is the answer. But don't be afraid of low molecular weight heparin, not a criteria to avoid the TPA. No need to avoid low molecular weight heparin in a patient who's received alteplase. Patients who have disabling strokes are at risk for major depressive disorder. Definitely want to screen these patients, not in the hospital, but later, and treat them if positive. However, do not do prophylaxis. Wake-up strokes. It's all about last known normal. So if you went to sleep, woke up with symptoms, you'd have to go to whenever the time was last, generally outside the window for TPA. As we said earlier, it's both the time and the imaging. Specifically for wake-up strokes, it's likely that the symptoms started upon waking up. And so you use not only the time, but also imaging, whether it's the proof of an infarction that's old on the CT or perfusion imaging showing that there's a lot of brain left to save. Wake-up strokes are now no longer excluded from TPA. It's a more complicated decision to get there. And lastly, there is opportunity for recovery. And the biggest gains are going to be seen in the first week, but improvements persist up to a year. The brain is plastic, and so the smaller the stroke, the areas around the stroke can take over responsibilities for it. Thus, ongoing rehabilitation is meaningful. Right, we talked about the types of strokes, most of which are not those that respond to alteplase or thrombectomy, hemorrhagic stroke, hyperperfusion, or any of the others. Obstruction strokes is what this lesson was about. Obstruction strokes are supply ischemia, focal blockage. Generally, the substrate is atherosclerosis. Hypertension and diabetes, CKD, dyslipidemia, obesity, age. Any focal neurologic deficit, but I want you to recognize the anterior cerebral artery as feet and legs, motor sensory, MCA, face, hands, swallowing and speech, motor sensory, and PCA, vision changes. The workup involves non-con CT to rule out a bleed. Bleed is white. Dark gray is old infarct. The one you want to intervene on is normal. Then CT angiogram and a perfusion study. Practically, you're going to get this non-con CT and the CT angiogram at the same time, but you use the angiogram and perfusion study to determine, do you do endovascular thrombectomy? No need for the perfusion study within 6 hours of onset. You're going to answer the questions, do I do TPA? Get them under control of the blood pressure, look for excluding criteria, then use imaging and time to decide. Endovascular thrombectomy, can you get to it using the CT angiogram? Is it worth doing perfusion study? Control the blood pressure based on whether they receive TPA or not, 220 over 120 for permissive hypertension, then 185 to 110, to continue 180 to 105. Get an antiplatelet on board. It's aspirin 325, then 81. The 325 comes first day for no alteplase, hour 24 after a repeat CT with alteplase. And then all the while, you're going to be working up the etiology, telemetry and echocardiogram, and either a CTA or a duplex ultrasound for carotid artery stenosis. Consult PTOT, speech therapy. It's atherosclerosis, so treat atherosclerosis. Platelet monotherapy, high potency statin in control of risk factors. Is it a bleed? CT. IV TPA, time and imaging. Endovascular thrombectomy, can you reach it? CT angiogram. Perfusion study, is it worth it? Etiology, CTA or an MRA. Duplex ultrasound can replace the CTA for carotid artery stenosis. Telemetry, echo, bubble study only in very specific patient populations. MRI is the best test if a TIA, DAP for 21 days. If they do undergo hemorrhagic conversion, you'll know because of a headache or new focal neurologic deficit. CT, stop the TPA, call neurosurgery. And then don't do seizure prophylaxis, don't do depression prophylaxis, do DVT prophylaxis, and make sure you work up patients for major depressive disorder. Wake-up strokes are now no longer excluded, and recovery can continue for up to a year. And that is stroke.